So when it comes to agents who can't use oral formulations for whatever reasons, then you can consider this agent. And they are also very good when you are starting with somebody with a very high fracture risk. So those individuals with more than 20% in 10 years after doing the calculation, let's say somebody comes with 30%, 40%, then there is high fracture risk. These agents are very good, and they are also available in injectable forms. So if you don't have the chance to do oral administration, you can fall on these agents, the injectables. Ibandronate, which is a bisphosphonate, and raloxifene. Remember, raloxifene is a mixed estrogen agonist stroke antagonist. These two agents may be appropriate initial agents when it comes to some cases where the patient required drugs with specifically spinal issues, so vertebral fractures. In particular, you may consider ibandronate or raloxifene. Raloxifene, especially in postmenopausal women, could be considered. But always remember that it is still an estrogen. And therefore, if there is any history of thromboembolic problems, you run away from raloxifene. Now, you have given your medications. You are doing all other non-pharmacological inputs where we will talk about when it comes to counseling. How do you monitor, especially for success? As for toxicity, you are looking at the side effects and the potential problems that these drugs can cause. But how do you monitor for success? So initially, when the patient comes, you need to obtain a baseline. That is the starting point when it comes to the person's T-score, dual energy X-ray absorptiometry. You need to get a baseline before you initiate your therapy, so that subsequently, if you try or you start your intervention, the ones that you measure, you will compare to the baseline. That is the only way to, as in, enable you to know whether you are winning or you are losing. Obtain a baseline dual energy X-ray absorptiometry. Start your intervention and repeat this test every 1 to 2 years. You do this, you modify your therapy until you get a very stable and a very favorable dual energy X-ray absorptiometry measurement. So you'll be monitoring and doing your treatment. Then you continue with a follow-up dual energy X-ray absorptiometry every 1 to 2 years, or at a lesser frequent interval, and this depends on the outcome. So if maybe initially you are getting promising figures and it did not take much time for the patient to have stable and favorable measurement, then of course you can't extend the duration of measurement. But in those that you are not getting even closer to your target, it means that you would need frequent measurements because you're obviously going to do frequent modification of the therapy. And also monitor changes in lumbar spine, total hip or femoral neck bone mineral density, of course. These are the key areas where you have problems. So you monitor. You monitor by using dual energy X-ray absorptiometry. But there is an issue with this measurement. There's an issue with this measurement in that if you change the machine, normally the one that you use for the baseline, if you change the machine, then another machine can give you different results that you can't compare it to the first one that you did with a different setup. So normally it is preferred that the same machine that you use initially for baseline and further assessment, it is preferred that you use the same machine. It doesn't matter even if you go to the same hospital. If you go and they've changed the machine, it can also affect because it's not the same machine. So the hospital doesn't actually matter. But you have the chance of using the same machine if you utilize the same hospital. So that is one disadvantage when it comes to the dual energy X-ray absorptiometry. It's just like these medicines that they say don't change brands. If you are doing well on one brand, stick to that brand, because the moment you change it, then there could be issues. So something like these thyroid medicines, normally you have to stick to a certain brand. If you change it, it may not work as the one that has been good to you. So that is one thing that we have to know. All right. Now, how do you monitor treatment outcomes? Monitor, because all these measurements and whatever monitoring, we are saying that we are going to look for what outcomes. That is why we are doing monitoring. Now, we have situations where you can have positive outcomes or treatment failure. So when do we say that per the monitoring, we are having positive treatment outcomes? So general therapy for osteoporosis, when the person comes with stable or increasing bone mineral density with no evidence of new fractures, then we know that we are at winning. So bone mineral density is improving, fractures are no more. Because if you have osteoporosis, your chances of getting fractures increases. Now, our target was to avoid fractures and increase bone mineral density. In general, we are having that. It means that we are having positive outcomes. In respect to anti-resorptive agent obviously is going to block osteoclastic activity, and therefore we are not going to get bone motion. In this case, when bone turnover markers are very low, then we know that we are chopping success, because you don't want the bone to be what? Be breaking. If the bone, then the markers will be seen in the blood. So if you are using an agent that prevents bone breakdown, bone resorption, positive outcome is that you are not seeing bone turnover markers. You are not seeing high amount of alkaline phosphatase. If you see high amount of alkaline phosphatase, it means you are having bone resorption. That is why you are having high amount of alkaline phosphatase in the blood. Meanwhile, you claim that you are using a drug that prevents resorption. If so, then you shouldn't see alkaline phosphatase in the blood in high amount. So with respect to anti-resorptive agents, we expect that we don't find the bone markers in high amount. However, if you are using agent, anabolism is building up, then it is the opposite. Positive outcome means that you have increase when it comes to bone formation markers or bone turnover markers, because you are building these bone markers to deposit them in the bone. So depending on the type of agent you are using, positive outcome in terms of bone markers could be one. If you are using an anti-resorptive agent, you are preventing bone breakdown. If you are preventing bone breakdown, you don't expect to see the bone markers in high amount, because if you see them, then it means you are breaking the bone. However, if you are using anabolic agent, teriparatide and denosumab and those things, we are trying to build up the bone. So all the markers, all the things, collagen, type 1 peptide, whatever, phosphatase, those things, we expect them to build up and sit them in the bone. And therefore, for anabolic agent, you expect the opposite. Seeing more of these bone turnover markers is positive when you are using anabolic agent. Meanwhile, when you see them more, when you are using anti-resorptive agent, then it becomes negative. So for anti-resorptive agents, positive outcome means low turnover markers. Whilst for anabolic agent, positive outcome means high bone turnover markers. When we say that we are having treatment failure in osteoporosis is not about having just one fracture after initiating treatment. Having just one fracture is not enough to say that the treatment has failed. So one fracture is accepted. But when you have 2 or more fractures whilst you are on treatment, that becomes a case for you to confirm that there is treatment failure. So note that, yes, even when you are on treatment, you could suffer maybe 1 episode. That is no problem. But if it becomes 2 or more, then it means that you are having an issue. So recurrent fractures, recurrent means 2 or more is negative. One-time fracture on treatment doesn't qualify anybody to declare that there is treatment failure. Any queries? Any queries? Class captain.
No, please.
All right. So being on this treatment, is it going to be lifelong, or there is a time that you can stop? Duration of therapy. When are you going to stop this treatment? Is it going to be part of you for life, or you can stop? Let's look at it. This depends on the success that you will chop and the type of medicine that you are using. So these 2 factors largely influence when to stop the treatment, your choice of agent and the positive outcome. Now, the guideline says that you are to limit treatment with abaloperatide and teriparatide, that is these 2 anabolic agents, to 2 years, and continue with any of the bisphosphonates or denosumab. So it means it's not advisable to use daloperatide, abaloperatide, and teriparatide for over 2 years. So when you use it for at least 2 years and switch from these agents to a bisphosphonate or denosumab. Very good. Limit treatment with romosozumab to just 1 year. So romosozumab, you are doing just 1 year. Sclerostin inhibitor, you are doing just 1 year. And then follow with a drug intended for long-term use, obviously bisphosphonates or denosumab. Then for oral bisphosphonates, if you are on them, consider bisphosphonate holidays. Holidays means you are going on break. After 5 years treatment, if fracture risk is no longer high, as per the dual energy X-ray absorptiometry and the fracture risk assessment, and of course, evidenced by fracture-free episodes. At continuing treatment up to additional 5 years if fracture risks remain high. So it means for bisphosphonate, you can do up to 5 years and break depending on the outcome. If the parameters are favorable, 5 years, you stop. But if you do and still you realize that you do the fracture risk assessment at 5 years and it's still high, then you have to continue on for additional 5 years if there need be. So that is for bisphosphonate. Again, for oral bisphosphonate, you consider bisphosphonate holiday. So this is the same as what we have said. So after 5 years, you go on holiday if parameters are okay. If they are not okay, you continue on for up to another 5 years. Okay. So for zoledronate in particular, though it is a bisphosphonate, but that one, consider bisphosphonate holiday after 3 years. So typical of MCQs, they can bring this one out and say, compare it with other bisphosphonates. Which of the following bisphosphonates calls for stoppage at 3 years? So they bring alendronate, ibandronate, etidronate, and zoledronate. All of them can take them for 5 years, but zoledronate, they are saying you can consider a bisphosphonate holiday when you are using zoledronate after 3 years in high risk patients or until fracture risk is no longer. And then typically discontinue, continue for up to 6 years in very high risk. So for most of the bisphosphonates, you are continuing to about 10 years, but for zoledronate, you are stopping or you are going on holiday if parameters are okay within 3 years. If not, when you continue, you can stop at 6 years. So that is the odd one out of all the bisphosphonate agents. Now, the ending of a bisphosphonate holiday should be based on individual patient circumstances, such as an increase in fracture risk or decrease in bone mineral density beyond at least the significant change by using the dual X-ray absorptiometry. Of course, this is how every treatment is made. We have given a recommendation that do for 5 years break and continue for between 6 to 10 years. But in general, individualization is the way forward. The fact that we are saying do this doesn't mean that in all patients you do. You need to individualize the therapy, use the appropriate monitoring tools, and take the appropriate decision. Now, a holiday is not recommended for non-bisphosphonate anti-resorptive drugs. Remember those ones, when you are stopping, then you are switching to bisphosphonate. It's not like you are stopping altogether. So we said you can use some drugs for about 2 years and you switch. So we don't have holiday for them. And treatment with such agents should be continued for as long as clinically appropriate. If denosumab therapy is discontinued, patients should be transitioned to another anti-resorptive agent. We've mentioned this already. Now, can we do combination therapy? Can we add raloxifene and maybe do bisphosphonate and do denosumab? The current guidelines recommend that it's a no. It's a big no. So currently, the guideline does not recommend concomitant use of agents for the prevention or treatment of osteoporosis. So one agent at a time. If you are using a bisphosphonate, do it. If you are using teriparatide, do it. Don't do combination therapy when it comes to these agents. Class captain, any queries? Hello, class captain.
Doc, please, no queries.
All right. So now we will take advantage of the counseling and look at some few non-pharmacological management as part of to augment the pharmacological management. So fundamentals, measures of bone health. These are the things that you need to incorporate when it comes to the counseling and the non-pharmacological management. So of course, you can measure your calcitriol levels, your vitamin D levels, and guide you when it comes to diet and those things. Always make sure that you keep it at a high, normally between 30 to 50 nanogram per mil. In that case, if it's below, then you are going to try maybe calcitriol or any vitamin D containing agent. If maybe you don't have the chance to do drugs, you can also do as an engage a dietitian for the person to recommend some food substances that contains high amount of vitamin D, as well as calcium. So for example, you have high containing calcium diet like spinach, soya beans and oranges and whatever. The target is to provide such individuals with at least 1,200 milligram of calcium per day, especially those above 50 years. They are at increased risk. Your target for vitamin D is between 1,000 to 2,000 units per day. Of course, you should counsel the patient to avoid all the lifestyle that will predispose the patient to osteoporosis. You have alcohol here. This one is supposed to be avoid nicotine, avoid smoking. I'll add it before I send it to you. Nicotine has been demonstrating bad moves against osteoporosis, and therefore, as part of the counseling, the patient should stop smoking, but limit alcohol to not more than 2 units per day. Remember, we said lower units will even give us benefits. So we don't advise that you stop. You can stop though, but if you can't stop, don't go above the 2 units per day, 14 units per week. And of course, you should also counsel patients to maintain active lifestyle. Sedentary lifestyle, bone inactivity can lead to atrophy. Of course, stop taking unnecessary things, sodium containing things, you eating too much sodium. Remember, it doesn't help in bone health. Risk of falls, because if you get osteoporosis, if you fall, you are getting fractures. And therefore, it is very important that you give the person counseling points on how to avoid falls. If the person is having any eye problems, he should seek the specialist intervention to treat the eye problem. If there are balances and movement disorders, appropriate treatment or interventions must be done, and several other things the patient can do to avoid falling. You can be using sticks, walking sticks, or whatever, or you use wheelchairs so that you don't fall. Any question? If not, then this will be the end of our osteoporosis discussion. Last captain, any questions, any information, any announcement?
Doc, please, I have a question.
Okay.
With the bone resorptive markers, particularly the ALP, given that ALP can also be elevated in liver conditions, particularly related to the bowel and canaliculi, when you do your LFT, what upper limit would kind of give you an idea that this is probably coming from the bone or this is probably